welcome to Psychiatry Bootcamp Season 3. I was initially going to title this season, Call Me, Beat Me, If You Want to Reach Me, but after literally no one commented on the Kim Possible sound effects in the trailer, I've decided that I'm probably not as funny as I think, and so the season shall remain nameless. This season, we're talking all about consultation-liaison psychiatry, which is where I have been practicing during my first year as an attending. I've done my best to design a curriculum that will help us understand how we can embrace our role as healers during what is sometimes a one-time interaction with a patient. We're then going to cover some of the most common topics that come up on consult services. As with the last two seasons, Dr. Alan Francis is going to set the stage for us by talking about the unique role that consult psychiatrists play in today's healthcare system, and by providing a framework for understanding and helping each individual patient. While he needs no introduction to this audience, Dr. Francis was the chair of the DSM-IV task force for the American Psychiatric Association, and he is the former chair of psychiatry at Duke University. He is also my favorite psychiatrist on the planet. Dr. Francis, welcome to Psychiatry Bootcamp. Psychiatry Bootcamp is brought to you by Simple Practice. Simple Practice makes documentation, running your own practice, managing patients easy, and it now has an AI-powered note writing tool integrated within the EHR. So it's a true all-in-one EHR that is HIPAA and HITRUST compliant and has AI-powered documentation embedded within the health record. It also has PDMP checks integrated within the portal and really easy-to-use lab order templates. Simple Practice saves you time so you can focus on what matters most. Psychiatry Bootcamp listeners get an exclusive 30-day free trial of their AI note-taker software and a exclusive 7-day free trial and 50% off of 4 months for the full Simple Practice EHR. Visit simplepractice.com/bootcamp to learn more. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. So really excited to bring you a ridiculous deal from Beat the Boards. It's not a discount. It's completely free. Free access to over 4,400 exam stock questions for USMLE Step 2 and free access to over 4,500 questions for Step 3. Completely free for Psychiatry Bootcamp listeners. Don't miss this opportunity. Go to beattheboards.com/bootcamp to get started today. I'll tell you that I use Beat the Boards to study for my own exams, and I really found that it made the exam very doable on exam day, alleviated some anxiety, and left me well prepared. Give it a try, completely free. beattheboards.com/bootcamp. Welcome back to the podcast. Dr. Alan Francis here to start off Season 3 with us. This season is about core topics in consultation liaison psychiatry. Dr. Francis, did you spend much time on consult services throughout your career?
I've always been interested in consultation liaison. I never worked full-time on it, but often did rounds.
And you mentioned that you saw patients in the ED, so I imagine that was quite a similar experience.
Constantly worked in the emergency room. So whatever job I've had during my career, I always felt the emergency room was the most crucial spot to understand the community, the problems of the people, and our system. So whatever job I had, I always spent 2 or 3 days, mornings a week going over in rounds with the residents and seeing some of the patients they had seen during the night.
So consult psychiatry really exists in the space between internal medicine and psychiatry. Like the ACLP, for example, used to be called the Academy of Psychosomatic Medicine, which I think gets this point across really clearly. And I think on consults, it can be easier than anywhere else that a psychiatrist is practicing to sort of leave our therapy hat behind and think that we are using lab tests and imaging and adjusting medications, and that we don't really need to be a therapist because we're just there to be a physician, so to speak. Where do you think that psychotherapy, broadly speaking, fits into consult liaison psychiatry?
Well, first of all, I think that psychotherapy is part of every physician's contact with every patient, not just psychiatry. So the idea that doctors are just reading lab tests and prescribing based on the results of studies rather than knowing the patient is, I think, a kind of abomination of modern medicine. The fact that doctors have panels that are too large, no time for getting to know each patient, makes for very bad medicine, makes for serious mistakes. And I have contact now with lots of people my age who are seeing doctors, and it's just remarkable how poor the care is, partly straight to medical care, because if you don't know the patient, you're going to prescribe medications that will interact with the other medications. But we've prescribed treatments that make no sense for that person, although they may be in the guideline for people who are younger and so forth. And the idea that clinicians of all sorts are now typing into their computers rather than looking at the face and getting to know them is a great, I think, indictment of modern medicine. Psychiatrists should not fall into this habit, that we should realize that every patient contact is potentially the most important moment in that person's life. And we should always be aware of the fact that there may be a magic moment, something we can say, something we can do that will make a major difference. I've treated people for years. I treated one patient for 14 years. I saw her once a week for 14 years and had absolutely no impact on her life. That I couldn't stop because stopping seemed more dangerous than continuing, but continuing did not help her. It just made for status quo. I've On the other hand, the opposite extreme, I've seen, I don't know, many hundreds, maybe thousands of patients for 15 minutes in the emergency room. So they come in during the night. The resident was doing their best to understand the situation and deal with it. I would do a 15-minute interview in the morning, and that would lead to saying, "Doc, you may not remember me, but you said something that changed my life." It's possible to have very long, intense relationships with people and have no impact. It's also possible to have very short, intense relationships with people. And if you're there at the right time and say the right thing at a moment of crisis in a patient's life, and every medical illness is a crisis for every patient who has one, you can make a great deal of difference.
So we're here to talk about these magic moments and hopefully understand some of the principles that we can use when trying to create these magic moments. I'd like to ask you, though, to paint a picture for us first, because you've mentioned that in a previous podcast as well, that you see these people years down the road and they mentioned to you that in a particular moment, something was said, something was done that really changed their life forever. Could you tell us one of these stories, kind of paint a picture for us of what this might look like?
Probably not. But if it's not as if one thing's going to come to mind, but I can give you a kind of general sense of it.
Yeah.
Patients don't come to doctors at good moments in their life. And particularly on a consultation, they're probably having one of the worst days of their life. Uh, Things are terrible externally, uh, things are terrible internally. The person is very uncertain about what the future will hold. They'll be looking at your eyes to wonder about whether the message is a good message or a bad message. There's lots of magical thinking in moments like that. Um, One of the best ways of understanding this is to be a patient yourself and have a difficult time in your life, and your whole perspective changes. The whole world seems out of joint, and everything takes on a significance that's much greater than the everyday. At moments like that, the right thing happening can be the beginning of a virtuous cycle of seeing the world more optimistic, finding ways to interact with your problems that will help solve them. The opposite can also happen. It's very easy for patients in the moment, particularly of medical illness, to fall into demoralization, to feel that nothing's going their way, that they're uniquely damned, that they're uniquely alone, that the future looks bleak, that they're helpless to make it look better. Patients seen in a hospital are almost uniformly at the most difficult, if not the most difficult, one of the most difficult points in their lives. Every person comes into the room, they'll be looking at their eyes and wondering whether they've seen a test result that means they're going to be dying of cancer, or maybe that I'm getting better. The major complaint patients have is that no one listens to them. Very often, the person who they feel is most sympathetic is the medical student because they actually sit down and spend time with them. The feeling is that mm, being in a hospital may be the loneliest place in the world. The Everything is noisy. People are running around doing not what. You may have all sorts of plugged in you and little blipping machines that you don't understand. You're probably sleepless. It's very hard to sleep in hospitals. People come wake you up in the middle of the night sometimes to poke something, take a blood test, give you a medication. There's nothing more unpleasant in the world these days short of a torture chamber than being a patient in the hospital. Someone who comes into the room and talks to you and listens to you and tries to understand what you're feeling and what your questions are, what your fears are, that can be the most important lifeline towards a sense of belonging in the world again, in a situation in which you seem to be drowning on a life raft that's leaking. So I think that just the setting of the consultation liaison visit by itself makes it one of the more charged human experiences a patient can have. Now, one of the problems here is the asymmetry. So from the point of view of the doctor, the resident, they're doing a job. They may be tired, maybe the 15th patient they've seen that day. They're walking into a room with a stranger. It may not be the most exciting moment in their life. It may feel like another routine visit. I've got to get through this whole list of patients today and get home before midnight, write my notes. From the patient's point of view, that may be the most important thing, one of the most important things in their lives, what happens next in the hospital. For many people, it feels like a life and death experience. And for some people, it is a life and death experience. What happens next in the hospital? So the first step, I think, is an attitudinal change in us to get over the asymmetry that this has to be to us a very important event. Maybe not as important as it is to the patient, but we have to be empathic to the fact of how important it is to the patient. We have to respond to this opportunity to be with them with the realization that we can make a great deal of difference in the next 15 or 20 minutes, with the patient coming out of this feeling understood and understanding more about what's happening, or the patient feeling even more lonely, more frightened, more uncertain. And the great risk with medical illness is demoralization. Of all the things that we can do with people who are suffering from medical illness, the most important thing we can do is to give them a realistic sense of hope, to reverse what's the most common secondary result of medical illness, the feeling that they are not in control of what's happening, that they can't understand what's happening, that no one really is talking to them about what's happening, and a sense of passivity and hopelessness, and very often inactivity that makes whatever the illness is that much worse. So walking into the room, it's important for us to feel that of all the things I'm going to be doing in my work life, this is the most important. That if I come out of this 15 minutes having somehow or other explained something, um, given a sense of perspective, provided useful information, um, invoking some hope with someone who previously felt hopeless, giving someone to feel understood when they felt that they were adrift, then I've done my job. That's why I went into this career. The rest of my career is kind of not that important. I felt much more important during the times I spent with people in the emergency room than I ever did at chairman's departmental meetings, or uh, writing a grant. Or when I think back upon my career, I'm not thinking about grants I had. I'm not thinking about meetings I attended. It would be the sense of having been helpful. There's nothing in my life that meant more to me. Well, maybe not my life, but nothing in my career that meant more to me than those people who came up and said it made a difference. And I think the first thing about making people better doctors in consultation liaison is not so much a checklist guideline of how to do an interview. It's an attitudinal change. That this is very important. What I'm doing now is very important. And most of the things I say in life, most of the things I do in life are not that significant. They don't, most of us don't have much of an impact on our world and the people around us most of the time. But in those moments with people who are suffering acutely, I can do more to help them than I can do almost in anything else I do. And each of these visits is special. Each of these visits needs to be felt as potentially magical.
It strikes me that so much of what we do as therapists, as psychiatrists, is really planting seeds. And when you're talking about your 14-year relationship with the patient, right? You're planting so many seeds along the way. You're fertilizing it. You're turning over the soil. You're watering it. You're doing your best to see an outcome. On consults, I think, like you're describing, we're dealing with really fertile soil because we're dealing with people who are being forced, sometimes by life circumstances, to have to see things differently because they don't have a choice anymore. And we are in a unique position as psychiatrists to offer them a different way of seeing things. I think one of the reasons that I am so drawn to pretty much everything you write and everything that you say is that it is so intuitive. I don't need a randomized controlled trial to tell me this because as you've mentioned on the nose, I have felt it from both sides of the interaction. And so I know in my bones that it's true because it's consistent with my experience. When I'm thinking of the different ingredients that go into making a magic moment, one of the things that has always been intuitive to me is it's important to be in some way unexpected because you mentioned this demoralization. I think of our patients in ruts, they're stuck. They can't get out of this rut that they're in. And sometimes I'll even use the word, maybe it's abrasive a little bit, kind of nudging our patient that it is time to change, that this is not working anymore. But I've always wondered unexpectedly what, unexpectedly compassionate, unexpectedly understanding, patient. And I think what you're making me think is it's just unexpectedly human, unexpectedly authentic, being with someone in a really deeply human way in the moment that's what they need is that human connection, which I think is sort of what our soul craves the most.
I think, Mark, that's a wonderful way of putting it. My less elegant way of putting it has been that the first step is you have to get the patient's attention. That
Yes,
the patient in the hospital is bombarded by people walking into the room.
right.
Most of them in the room unannounced. The person in the bed doesn't know why they're there. Most of them sort of bustling around, checking this, checking that, writing a note and leaving,
Exactly.
and providing them with very little understanding. So part of what you can do is providing a cognitive frame for what's happening. Also providing very little support and very little advice about how to best deal with it. I think that the best way of getting the person's attention is by looking them in the eye, sitting down and taking some time and asking very simple human questions about how they're feeling, not just physically, but what's it like for them being in the hospital now? What's it like for their family? What's their situation at home that they left? What's the situation they'll be going back to? Um, how is this illness affecting their work life? Being in the hospital for many people is a terrible catastrophe, not just physically, but in terms of their relationships with other people, their ability to support themselves. The biggest source of bankruptcy in America is medical debt. So when people are in the hospital, they're very often worried about how will we pay the bills for this. Um, the Being away from family, it's a terribly lonely thing, uh, especially at night, but throughout the day, being a patient in the hospital. You're an object. People come in and jab you and do this to you and do that to you, send you into these terrible boxes for imaging studies. And the sense of being at the mercy of this system, um, we might see the hospital as a benign system, but from a patient's point of view, it really isn't. It's a dehumanizing, anxiety provoking, scary place to be. And to realize the human element, that the fears, the dread, the sadnesses, the feeling of loss that is almost universal in someone who has an illness and is in the hospital is crucial. I think that what I read a paper when I was a resident that stuck with me throughout my life. It described a method of interacting with patients that depended on quickly establishing in your own mind their personality tendencies and realizing that during a hospital stay, you don't challenge these tendencies, you tend to support them.
Exactly.
So if you have someone who's an obsessive compulsive, master of his fate, who's constantly worried about controlling the details of every aspect of his life. The uncertainty of being in the hospital is especially painful and scary. So, with that, you want to give lots of information. What questions do you have about your illness? What questions do you have about the tests you're getting? What questions do you have about the options for different treatments? Of course, a lot of this should be done by the physician in charge, but often isn't. And so the consultation liaison doctor is forced into the breach often as the missing link of someone who's going to actually talk to the patient about what's going on. And especially with someone who's obsessive compulsive, you want them to know a lot and you want to give them as much control as possible. And that's hard to do in the hospital, but it's part of the planning when they go home that they will be very much involved in the choices of treatment, that options will be presented, they get to pick, that they will be involved in the deciding which medications work best, and what would be the uh, best way of organizing the daily ritual of taking medicines, how they might be doing a diary on side effects, and so forth. You want to give them a sense of obsessive control in a situation, compulsive and obsessive control in a situation that feels for them very out of control. If you have a dependent patient and you do the very same thing, it's going to make them feel even more terrified. Asking a dependent patient to take control of a situation that feels out of their control, giving them a lot of responsibility for the options and for how to proceed with the treatment will make them much more anxious about the situation. With a dependent patient, you might take more control of the situation, give them fewer options, help advise them towards the best choice for them rather than expect them to master the situation. Histrionic patients admire, narcissistic patients admire that they're feeling a tremendous blow being in the hospital. It's a horrible fate to be someone who's used to being admired and suddenly is a patient in the hospital wearing a gown, uncertain about what life will be like if a breast is removed, uncertain about what life will be like after a heart attack. Will I still be master of the universe after I get back to work having had a heart? In these situations, admiring the person, finding what's been most attractive about them, giving them a sense of worth, um, that will be more important than giving them information, which would be what you're doing with an obsessive compulsive person, or giving them advices, which is what you'd be doing with the dependent person. With paranoid individuals, and paranoia is easy to feel. If people have any tendency at all to paranoia, the hospital will select for it. It's important to fill in the empty spaces that they can form um, fearful cognitions about. So the more they don't know what's going on, the more likely a paranoid person is to think the worst. Are these doctors really doing this because they want to make more money, or are they doing this because they care for me? Is that why they're doing all these tests? Are these tests going to be more helpful to me or more harmful to me? Taking a position of neutrality in terms of their fears, concerns, but then exploring them and thinking about the pros and cons of each activity and letting them feel that they know what's going on, that there's less uncertainty in the situation can be very helpful. If you have a person who's very dependent on human contact, you should try to see them a lot and try to get very much involved in what they're feeling. If you have someone who's kind of on the schizoid side, that kind of what might seem like warm human interaction may be seen as threateningly intrusive. So the notion that the paper prescribed, and which I followed throughout my career, was to try to very quickly understand what kind of person is this? What are the personality features? Not necessarily disorders, but features. And to try to gear the way I would behave so that the experience together is a corrective emotional experience for the person rather than a further traumatic one. And probably in a few minutes we'll get into corrective emotional experiences because I think that's what most leads to magic moments.
Well, let's get into it then. And my next episode actually is with your longtime collaborator John C. Markowitz about supportive psychotherapy, and that's a sort of what you're getting at there is shoring up the personality defenses that the patient does have, rather than digging, trying to do something that should take years of psychoanalysis in the 15 minutes that you have in the consult room. Let's get into the corrective emotional experience then. And of course, that's sort of one of Freud's original ideas, I feel, one of his most well known ideas. And you have a series of tweets that I have translated into a chalk talk for my medical students and residents that I call Is Freud Baloney? Because I think that in today's age, he gets a lot of disrespect for some of his past ideas. And I think it's important to call out which of his ideas we think we have better evidence for now that are maybe not very helpful, and which of his ideas we really need to be taking seriously because they should be a centerpiece in every interaction with a patient. So, my question for you: what are a couple of Freud's ideas that you think a consult psychiatrist must understand in order to create a magic moment?
Well, it's interesting. Freud was um, probably greatly overvalued in his own time and is greatly undervalued in our time. So most of the uh, ideas that were fundamental in Freud came from Darwin, and everyone in Freud's environment was very much influenced by Origin of Species. Darwin was the and one way I put it is that Darwin was the greatest psychologist of all time. What Darwin did was to say we are much more like animals than we imagine, not just in our physical morphology, but also in our psychology. That we're not born a blank slate, which was a popular view in British philosophy at the time. That we're born with a whole suite of behaviors that evolution has fashioned, and that we're basically primates with extra intelligence, but with a lot of the emotional reactions that our primate ancestors had. He saw the similarities rather than the differences that evolution had built into our ways of being, and that's what Freud. That was the starting point for Freud. That we are born with a variety of impulses, of drives, of behavioral tendencies that have been built in by evolution over millions of years. That we can't quickly change them just by reason, and that we're unconscious a lot of the forces that govern our behaviors that happen automatically that control what we do. We often will come up with a secondary elaboration explaining why we do these things, but often the reasons we do them are unconscious to us, and that the basis of therapy would therefore be to make this unconscious conscious. And insofar as we became more self-aware of the impulses that we have that we're usually acting upon without understanding, that they will have less control over us, we'll have more control over them. And that this will lead to a smoother adaptation, that the world is changing much faster than our impulses are changing, that we're not going to be able to just stop having the impulses, but if we're cognitively aware of them, we'll be able to exert a more refined interaction with our environment. So, as a result of that, his theory of therapy had to do with both making the unconscious conscious, but also seeing recurring patterns in the person's life that would lead to the way they're reacting to their current stressors. And that the treatment for this, Freud actually was not that interested in psychotherapy. He saw psychoanalysis much more as a research tool, and he was much more interested in understanding how people think and establishing a model of the mind. The great clinician circle, Ferenczi, and Ferenczi was much more alive to two basic things that I think govern all therapists since and are especially important in consultation liaison. Ferenczi was very much aware of the power of the relationship. So Freud was very interested in the transference as a way of understanding the person better, but less interested in using the transference as a way of producing corrective emotional experience. A corrective emotional experience was really the fundamental aspect of Ferenczi's contribution. That in the straight Freudian model, it was understanding your behaviors. And if you understand your behaviors, you'll be able to control and master them. Ferenczi realized, and Ferenczi's students realized, one of the Ferenczi students was Chandra Arado, who was the head of the analytic school I went to. And Chandra Arado said, kind of summarizing Ferenczi, that insight never cured anything but ignorance, that you had to have experience as well as insight to change your behavior. And the corollary of this is that what's most powerful in psychotherapy, what's most likely to produce magic moments in psychotherapy, is a corrective emotional experience. That to the degree that people can experience the world differently with you than they have before, or you're able to make an intervention that allows them to have corrective emotional experiences in their outside lives, that's most likely to lead to change. If there's any moment when someone is most susceptible to having a corrective emotional experience, it'll be when they're in the hospital and suffering from an illness. That at this point, they're very, very vulnerable, that the stable features of their personalities that may make them resistant to change in the way of seeing things and feeling things, those stable structures are challenged by the illness itself and the uncertainties this creates, but even more so by the situation they're in caused by the illness, being in the hospital or being in an outpatient clinic after having a severe illness. And so at these moments, people could make much bigger changes than they would make during the everyday. And I think that to the degree that we're able to give someone an insight into I'll give you an example now. I have several friends who are dying of cancer. You reach my age, almost everyone you know is sick. And the I think corrective emotional experience I hope helpful in allowing them to have is the realization that we're all dying soon. That at my age, we all face death, whether it's in a few years or a few months, and that it's not so important how long it is. What's most important is how rich it is, the remaining period of life. And for some people, understanding that changes the way they see the rest of their lives. And it only takes a few minutes to say it, and it's not always going to work. And it's not going to work completely. It's not going to be fun dying sooner from cancer than being relatively healthy, even though you're old and dying in a few years in the future. But it can have a deep meaning. Realization is that my enemy isn't just the fact I have some cancer cells. I shouldn't overvalue the effect the cancer cells have on my life. That we all have a terminal illness, and it's just a matter of when. And I'm going to be able to deal with this if I understand better that the quality of my life is more important than the length of it, and I can make the remaining time uh, as pain-free, as comfortable as possible, but also as meaningful as possible. That would be one example, but the issue is in a short consultation liaison experience, how much can you come to understand what's the patient's most basic fear, most basic concern, and can you say something that will help change the way they see that will give them a sense of greater mastery over the situation, give them a sense that they're not uniquely damned, that this is a problem that is human. It's a human condition. That we all go through things that are like what you're going through. You're having it more than most people have now, and certainly more than seems fair and is fair. But what can we make of the situation that brings some hope and some value to what you're experiencing, so it's not just a total negative? Now, will this work if someone's in chronic pain? Probably not. Will it work if someone's short of breath and they can't, they're not perfusing enough oxygen to their tissues? Probably not. So the ability to create a magical moment with a corrective emotional experience can be enhanced by the situation because people are ready to hear things a different way, and they're often grabbing at hope. Anything you say that gives them a life raft will be important. On the other hand, this won't work well if they're feeling chronic pain. And so a consultation liaison doctor has to also be a very good doctor. And one of the things I've learned is you can't trust the other doctors working on the patient's case, which they will often see the patient's case, to know about or care about some of the fundamental common sense things that make the world of difference for patients. Pain management being an enormous issue there. Um, Getting a night's sleep being ensuring that no nurse is going to wake the patient up to give them medication in the middle of the night unless it's crucial. Providing comfort care is enormously important as a background for anything else you do. And I think medications are important. I think the thing I found very useful medication wise during my with sick people, people who are um, unable or unwilling to get out of bed, who whose appetite is very diminished, who have no energy, who've given up emotionally or are being physically very hampered by their illness. Cancer patients frequently in this category is the use of low dose amphetamines as a combination pick me up for the physical problems and an anti demoralization medication for the giving up issues that often arise. So I think we're there just as best, not just as human beings who want to be helpful, not just as people who have special psychological understanding, that I don't think you can count on the medical system to always be doing the right thing for the patient. And we're also there as a form of quality control for the medical care. Patients are so often treated by doctors now as if they are a lab test, and each doctor is focused on just one aspect of their and missing the fact that when you add all the drugs they're getting, the reason that they can't move is more likely to be drug side effects from all the drugs and the interactions among the drugs and the fact that the dosages haven't been lowered as they've gotten older and people don't clear medicine as well as they get older. I think that we need to feel like we have some responsibility to make sure that the medical care itself is not being delivered in such a haphazard, atomistic fashion that mistakes are being made to be corrected. I think that when I was seeing consultation liaison patients, either in the inpatient hospital services or in outpatient clinics, the most common thing I recommended was to lower the dose of psychiatric medication. That the most common experience I had was that people were on too high a dose of a single medicine or were getting a combination, a polypharmacy of medications, and that new symptoms occurring in this context are very often due to the medication people are receiving, in addition to whatever the underlying medical problems are. So that more often, I think, we'll help by lowering medications than we will be by raising them in situations where there are new symptoms in people who have medical illnesses. So in any case, it's actually an absolutely impossible job to be in consultation liaison. It's the hardest, I think, job in psychiatry. No one wants to pay for it. So the medical surgical services think it should be psychiatry's responsibility. Psychiatry can't afford it unless it's paid for by the other services. As a result, it's underdone, and very often there are way too few consultation liaison physicians and psychologists and social workers given that's at hand. You're expected to do more with less time than in any other situation in psychiatry. So it's kind of, and you have trouble collecting. Everything about consultation liaison is difficult. The one thing that balances it is the fact that it's so rewarding. So there are very few arenas of human endeavor where a person can have such a positive impact on human suffering than consultation liaison psychiatry. But it's done swimming upstream against tremendous underfunding, uh, too little time with patients, and a system that's remarkably insensitive to patient need.
Feels very validating to hear all of that from you. One of the questions that I had written down, and I'm glad that you just went there and you already answered it, so I won't ask it to you, was consult that I have been seeing a lot is just people who are dying, people who just got a life changing diagnosis and they're going to die in the near future. And the question would be, how can I bring them comfort? How do I approach this patient when this is not a psychiatric disorder? This is just a normal part of the human experience. And how do you, sort of approach that patient? I think you gave us a really concise answer, so I don't feel the need to go further over that in terms of finding a way to help them understand that the goal now is not to prolong life, but to make the remaining life rich in meaning. So instead, my final question for you will be, what would you say to someone who rolls their eyes at the phrase magic moments? I mean, after all, magic can sound almost antithetical to science, evidence-based medicine, etc.
Well, first of all, let's be honest about science and consultation liaison. There's almost no research in consultation liaison, and it's almost impossible to research. The fact that the patients are usually being seen for such a short period of time, that many of them are not eager to be signing up for research studies. That it's not like there's an extensive science that's guiding consultation liaison. There's no research on polypharmacy. It's hard enough to compare one drug to another drug to placebo. It's almost impossible to compare two drugs to one drug, and it's never done. And most of the patients that you're seeing are probably on more than one drug. So it's not as if when you see a patient, you can fall back on, oh, there's a guideline for this. The patients are almost always so individual that all people are individual and all psychiatric patients are individual. But the most individual of all people and all psychiatric patients, someone in the hospital with medical illness, that the presenting problems are so varied, so heterogeneous, so comorbid across medical and psychiatric lines and social service lines, that every person presents a unique challenge. And when you're seeing a patient in consultation liaison, a few of them will be seen for psychiatric disorders, but most of them will be seen for existential crises. It's much less often, at least in my experience, that you're going to be giving a clear-cut, oh, this is the psychiatric diagnosis, this is the treatment, and everything's going to be fine. That the existential situation of being sick, the social and economic problems that entails, the way it changes relationships are so particular to each person. There's no manual that would provide a meaningful, ways of understanding it or treating it. But each time you go in, it's part of the excitement. Each time you go in, you're dealing with something that's fresh, and you're using everything in your experience, not just your psychiatric training. You're using everything in your experience to be helpful. So I think that maybe magic is facile, but what it expresses is the fact that this is not assembly line work. This is not linear work where you check off, I did this, I did this, I did this, I did that, and I have a finished product. This is nonlinear, more like chaos theory, butterfly effect. You never know what statement you make the person will remember, but you should try to find things to say that might be memorable. Most of the time, they won't be. The person has a million other things to be thinking about. They're seeing a million people. Most people will forget you and forget everything you say. But every once in a while, magic happens. Every once in a while, you say something that registers in a way that the person remembers years later when you don't remember them. And that's a wonderful feeling. I think the more poetically you can express things, the more emotionally you can express things, the more personally, feelingly, deeply, the more likely that the person will hear it in that magical way. But I wouldn't expect to leave. I think it's very important to go into every meeting as if this could be a wonderful moment in a person's life, but to never be disappointed if it's not, because most of the time it won't be. But when it is, it's special.
Wonderful. Those are very inspiring words for us as we embark on our third season about consult liaison psychiatry. And as I embark on my career, I'm sure I'll be coming back to those often. Thank you for carving out the time for us this morning, and we always appreciate to hear from you.
Well, Mark, I do these things a lot, but it's special doing it with you. So thank you.
Thanks. That means a lot. Thanks for listening to this episode of Psychiatry Bootcamp. If you enjoyed the podcast, please take a minute to leave a review on Apple Podcasts or a rating on Apple or Spotify. You can reach me at psychiatrybootcamppodcast@gmail.com. Find me on TikTok or Instagram at Psych Bootcamp. Our theme music is by Cave Radio. Special thanks to Matthew Braddock for production support. The opinions shared on this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice. This is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.